So hopefully we'll get slides at the very end, we'll see. So I understand this morning earlier, you all heard about all the important reasons why we should identify refractory epilepsy early and potentially look at patients, no matter what the age, for a surgical treatment for their refractory epilepsy. And Dr. Shah and I were going to touch upon the first portion of evaluating patients for candidacy for this kind of treatment, which in some cases can be curative for a diagnosis that does not have a cure. So pretty important. And in large part, a phase 1 evaluation involves a look at the brain's electricity, a look at the brain's structure, and a look at the brain's functionality. And all of those pieces get put together when we discuss each individual. The phase 1 evaluation may lead to a one-stage resection, meaning we do not have to record seizures intracranially, or it will lead then to further need for evaluation of an epileptic circuit by what is called the phase 2, and that gets discussed a little bit later. My intent, if we can eventually get to slides, was to actually share the story of one of my patients who was very excited to hear that her story was going to be shared here when I asked her permission. Her name is Sam. I saw her last week, 6 months post-op, and she's doing fantastic. And she has a really nice journey which sort of spells out what a typical phase 1 is for a pediatric age patient. I met her in adolescence, although her story began in early infancy. She was 8 months of age when she began having paroxysmal spells where she would stop doing something and look over to one side. And her parents promptly sought medical attention, and she underwent routine EEGs. I didn't have that data at the time, but she was appropriately diagnosed with seizures and put on a medication called oxcarbazepine, also known as trileptal. And she did okay, but still had some convulsive activity. In evaluation of why this infant was having seizures, she underwent neuroimaging by MRI. And it was discovered that she had what is called an arachnoid cyst in her left middle cranial fossa. So that's sort of right where your temporal lobe is. It's a very, very common area of the brain to have this benign cyst. Although there is some association with epilepsy, it's not a cause and effect thing. But for a long period of time, neurosurgeons thought if I just fenestrate that cyst and relieve the pressure of it, the patient will stop seizing. And so that is what happened to Sam. She was 14 months of age. She underwent surgical fenestration of that cyst, and people were confident, and so they took her off her oxcarbazepine, and a few months later she started seizing again. And so, okay, well, we just go back on our oxcarbazepine. And unfortunately, second time around, that failed to control her seizures in any meaningful way. She had multiple per day. She got put on Keppra, which then helped her. So for 4 years, Sam did not have any seizures. That's pretty good. That's actually longer than we would probably prophylax a child for seizures, but she was still on medication when unfortunately seizures recurred again. That's not an uncommon story. Sometimes we have these periods of these honeymoon periods, right, of seizure control. She got put on Depakote. That maybe helped control the bigger seizures, the ones that would start focally but would become generalized convulsive events, so that helped that, but she still had many of her focal seizures. And by menarche, she declared herself as refractory. So she was having multiple events, which multiple medical trials at therapeutic dosing did not stop. And that was about when she was referred to us for further evaluation and treatment. One of the first things that we did was re-image her. So we performed a 3 Tesla epilepsy protocol MRI, which is the structural piece of the phase 1 evaluation, a good MRI. Some centers on research protocol may go to a 7 Tesla MR. Some centers do special processing on 3T MRs post-acquisition, post-completion of the study. But a 3T epilepsy protocol MRI is sort of the standard, gold standard of how we look at the structure of the brain. Why is this young child still having focal seizures and why is it refractory? And although that image identified her very stable arachnoid cyst in that left middle cranial fossa, what we saw for the first time was a small focal cortical dysplasia in the opposite hemisphere in the way back, so in her occipital lobe. And if we can get pictures, that would be great. Okay, so we have an area of malformation, pretty common cause for focal seizures in a child or an adult. What else did we need in order to talk to Sam about a potential resective or laser ablative procedure that may help her epilepsy? Video EEG, right? We had lots of routine EEG on Sam, 20 to 40-minute recordings that were absolutely normal, not uncommon. There's a lot of the brain that's in the middle and a lot of the brain that's folded underneath, and the electricity generated from those areas don't always make it out to your scalp recording. So what we do in both adult and pediatric patients is bring them into monitoring units in a very safe way, provoke seizures out of them. Not big bad withdrawal events, but they're stereotyped habitual seizures is what we want to capture, right? And so that's what we did with Sam, and this often requires lowering of seizure prophylaxis medications, sleep depriving patients, having them perform activation maneuvers. And this brought out a ton of auras in Sam, and 2 bigger electroclinical seizures. So now Sam was older, and she was able to describe her seizures for us. They would always begin with a visual obscuration in the center, and then that would morph into a moving ball of color, of lights, that would then go up towards her left upper quadrant. Sometimes eyelids felt twitchy, and often outward observers, family and friends, would note that eyes would then conjugately verse to the left, and her head and neck would then turn towards the left. Those were her seizures. She was aware of the whole event. She was actually able to narrate throughout the whole event. And I had video of one of her seizures where she's actually correcting the tech about what's happening to her. She's like, no, I'm not going to the right, I'm going to the left. And so she was able to self-report all of them. They were troublesome, so they occurred 4 to 5 times per month, all the way up to 2 to 3 times per day. And then when she had her menstrual cycle, they could occur up to 8 to 10 times per day. The fancy word we give that is catamenial epilepsy. So seizures that are exacerbated by a female's hormonal cycle. And we tried very fancy things with medication to specifically target everything, and she still just continued to seize. So then we decided to move beyond our MRI, our structural way we look at things, and our phase 1 video EEG, which is the electrical way we look at things, to look more at the function of her brain. We performed what is called a PET scan, a positron emission tomography, that's in conjunction with a CAT scan. That is not necessarily a picture of the structure of the brain. In fact, if you've ever seen a PET scan, it's very grainy looking, not very much detail. It's actually a picture of how the brain eats. So the brain uses sugar, glucose, as its primary diet, right? You cannot feed it glucose for a couple hours and then give glucose to the brain tagged with something you can see on a nuclear radiology picture. Any brain that seizes is unhealthy. And what do we do when we feel sick? Well, we don't eat, we don't have a big appetite. So typical on a PET scan would be an area of what is called photopenia, where the brain that tends to seize is not eating glucose like it should. And you can take a picture of that. And we did that for Sam, and probably for reasons of size, her PET scan was pretty normal looking. There wasn't any large area of photopenia or decreased glucose uptake on her PET scan. But we were really worried that this area of MR abnormality and the area of electrical abnormality, which localized to the right occipital lobe in Sam, was very close to an eloquent function of the brain. Does anybody know what sits in the occipital lobe? What function we have back there? Somebody said it. Good, yeah. Vision. We had Sam undergo visual field testing. She had a partial loss of vision up in her left upper quadrant, which matched the area of abnormality in the right occiput. So like with a lot of neurological function, right brain takes care of left and left brain takes care of right. And so our right brain sees the left world. And so up here, she actually had an area of a vision loss that she was largely unaware of. She's very artistic, always drawing. And it wasn't until we formally tested her that she understood. Am I in your way?
No, you're good, you're good.
Okay, understood that that was part of her brain process and her brain disease, if you will. There are ways to map out functionality and eloquent areas of the brain. Maybe Dr. Shaw can talk about the functional MRI and the WADA, so I'll step aside for that.
So two ways that we use to look at the function of the brain when we need to know what could be affected if we did surgery, what's affected, which areas would be safe to resect or not safe to resect. The first test that is the WADA test, which is being used less and less now as technology advances, but it's still being used sometimes because that's, the best test for that. The WADA test is, so first of all, it's not an acronym. It's actually named after Dr. Wada, who invented the test. He's a Japanese doctor. What it does is it's a test where we essentially put half the brain to sleep and we test the awake side of the brain. And we test it with things like language and memory. And so the way that we put half the brain to sleep, a catheter, like a thin flexible tube, is inserted, usually from the groin, sometimes from the wrist, and goes up into the blood vessels for the brain. And something called sodium amylbarbital is injected, and that's like an anesthetic, and it puts that side of the brain to sleep. And so that lasts for a few minutes, and during this time, the person, adult or child who's old enough to do it, they will be shown various things. Can you name this picture? What's this? What's this? They'll be asked to maybe point at things, and they'll be asked to remember things. This will wear off after a few minutes, and once it's worn off and both sides of the brain are awake, then the person will be asked which things they remembered. What do you remember seeing? Did you see this? Did you see that? And so with the WADA test, we can see two things. We can see which side the language functions are on. In most people, it's on the left side of the brain, but not in everybody's. And sometimes we need to really check, especially perhaps if somebody's left-handed. So we can see which side the language is on, and then we can also see how their memory is. So for instance, if we were thinking that we needed to resect the left side of the brain that involved memory structures, we'd be really interested in seeing how the right side does all by itself. If the left is asleep, we need to make sure the right is able to, continue memory functions. And then we are also interested in seeing how much memory function the left has, and perhaps that would, give an indication of how much risk there would be for having memory decline if we did cut it out. So that's the WADA test. fMRI, which is functional MRI, is another test where we can look at a lot of functions, including language. We can look at vision, and we can look at motor. So this test is done in an MRI scanner, just like the regular MRIs that people have. But during the test, the adult or the child who's old enough will be doing certain tasks, such as tapping their fingers or tapping their toes, And while they're doing that, the MRI can get a picture of which parts of the brain are active while they're tapping their finger or tapping their toe. And that would give you information for where the motor areas are, the parts of the brain that control movement. So if our suspect area is near motor areas, then you might get a motor fMRI to check where those areas are compared to the areas you think you might be resecting. If we're interested in language, then you'll be doing language tests in the fMRI, or if it's vision, then the patient would be doing vision tests. So Sam had an fMRI that tested vision, right? Yeah. And then, as I understand it, kind of correlated with what we saw in the visual field testing with, certain areas back there were not really showing much vision function, right?
Yeah. We actually even went further, started.
Oh, yeah.
So there are other MR sequences using DTI, what's called tractography. So we were able to kind of visualize her optic fibers as they headed back towards occiput. And she had already remodeled her right side a little bit. So the dysplasia pushed her fibers to the side of it, and actually they traveled over it. And all of that was super useful for the neurosurgeon to plan his approach from the middle and from underneath, so that we could, keep the integrity of those very important visual fibers sort of intact. So that was helpful. Because we were not in area of medial temporal lobes and memory function, we did not have to perform the WADA test on Sam. But what we did do, which is what we do for all patients at baseline, is have them undergo a full neuropsychological test, which is a variety of standardized tests looking at executive function, at language ability, and motor ability, etc. Those are performed by neuropsychologists who are probably one of the smartest members of the team. Those are difficult tests to interpret because usually these patients are on 3+ medications, all of which have some effect on cognitive function. They've been seizing for many years, which has some effect on the brain, obviously. And they very commonly have comorbid anxiety and depression, which always affects the performance on these kinds of exams. So in Sam's case, she didn't have anything, frankly, lateralizing or focal in terms of dysfunction. We already knew she had some ADHD, which was detected, and we knew she had chronic epilepsy and was on 5 drugs. But other than that, she appeared to be functioning at a very good level despite all of her difficulties.
Okay. Yeah.
Sorry, guys, this is the second one.
Okay. All right. Thank you so much. Thank you. Okay. All right. No slides. Sorry. So just to sort of recap, for the phase 1 evaluation for both children and adults, will always consist of the video EEG, where you're waiting for seizures and getting the seizures and figuring out electrically where they're starting from. So there's always the video EEG, there's always the structural MRI to look at the structure of the brain, and there's always neuropsychological testing. Sometimes these 3 pieces of information is enough to figure out where the seizures are coming from, to decide if there's going to be a lot of decline or risk if you go resect that area, and the person can go to surgery. Sometimes that's not enough information, and we go on to further tests to help figure out which area of the brain is the problem. And so you may get a PET scan, like Sam did. You may get a MEG scan. There's one more test that I wanted to talk about, which is the ICTL-SPECT. So this is like a different way to look at where seizures are coming from. Are we short on time?
We're good.
Oh, okay. So if you remember how the PET scan is looking at what the brain eats, what the ICTL-SPECT looks at is how much blood is being taken up. So the idea is that at where the seizure is starting from, that area of the brain is taking up a lot of blood. So during an ICTL-SPECT, the patient is in the epilepsy monitoring unit again. They're connected to EEG, and you're waiting for a seizure to happen. And right at the beginning of the seizure, like in the first 10 seconds, we are injecting a radioactive substance. It's safe and short-lived. It's called technetium. This is being injected right at the beginning of the seizure, and the idea is that that part of the brain that's where the seizure's starting is taking up a lot of blood and is going to take up the most of that radioactive substance. So the patient will then get a scan, and then that's what we call the ictal spect. A second scan is needed, during which there's no seizure, and so that you can see what the regular background activity of the brain is like when there's no seizure. And then the neuroradiologist, with their fancy software, does this it's a subtraction process where they take the seizure scan minus the background scan, and then you get the blood flow that happened that was special only during the seizure. And then they take that and then they fuse it to the MRI, so now we get a really detailed picture. So many people don't need the ictal spect, but for some people, this is another piece of really useful information. I think that's everything we were going to talk about.
Yeah, in the interest of time. Yeah, I think Dr. Wheelis will come and talk about the MEGs. So what I would say, I think in the phase 1 evaluation, I think the piece that's most rapidly growing is the imaging of epilepsy. And so you'll hear next, I believe, about magnetoencephalography, which is a different way to look at brain dipoles and spike clusters. So all the brain's electricity generates magnetism, and so there are things called squigs, which are superconducting quantum interference devices which can record that magnetism. And actually Sam had one of these, and I can send you slides later if you want to distribute. Very, very, very helpful in another piece of information delineating that really it was only the area right around her focal cortical dysplasia that was irritable and active, and we could spare her a large resection and thereby spare her vision. So that's a very interesting way to look at things. And then lastly, there's something called source localization, which is actually just computer and software processing. You can use either EEG or MEG dipoles for this, or both, and using a computer figure out where the location of the generator of the electricity is and what direction it's going, and then put that on the patient's MRI. A great tool to look at the three-dimensional organ the brain is from the two-dimensional surface, right? So that is a very, wouldn't you agree, a explosive way we kind of look at things from the phase 1 evaluation, all of that non-invasive way we try and figure out the best thing for those patients surgically.
Before we start questions, I'm just curious how many people have told you or your child are not surgical candidates because the EEG or the MRI show something, so they stopped having the MRI. Okay. So that's generally a problem that we see as patient advocates, is that you're told, oh no, there's nothing on MRI or stuff is showing up on both sides, without going on to these other tests that are out there, like SPECT, like PET, like MEG, all these other assessments that might show that your child or you are a candidate for some other type of surgery, including neuromodulation. So happy to take a couple of questions now. We don't have a ton of time because of our AP issues. Do you have a question? Yes, go ahead. Of course, now the microphone's not working either. Anyone has short nails or gloves right now?
So my son went through the phase 1 evaluation, but it included the structural MRI, video, EEG, and PET. So there's two things. One is that based on the first EEG that you perform during this evaluation, do you have enough data to decide if that's enough, or do you need to go to more invasive EEG process? The second question, if you don't mind, is that the neuropsychology test and the fMRI, how they complement? Didn't get, not totally understand that.
Yeah, two good questions. Yeah.
You want to answer the first?
Sure. So in answer to the first question, it all kind of depends. So if a patient or infant has one seizure type, and we capture 3 to 4 of them on a video EEG, well-seen video, well-seen EEG, that usually is enough to say, okay, does it match something on the MRI, or it's focal, but I'm not sure exactly where, right? So the difference between, for example, lateralization and localization. Lateralization, I can say it's somewhere on the right, I'm just not quite sure where, versus localization, where it's, that's a right temporal lobe seizure. Depends on what your child does during the seizure, and it depends on what the EEG looks like. So in some patients, an MRI target and an EEG that at least lateralizes or regionalizes is enough for a one-stage resection, but it depends. It's a kind of an oversimplified answer. If the child has multiple seizure types, we need to capture all of them, and then we may only target the one seizure type that's most troublesome, or sometimes we can target several seizure types. It kind of depends. Now, if the MRI is normal, that doesn't mean, as Monica mentioned, that you're not a candidate. That just means we have to look at it further. That usually means that we get much more imaging, PET scan in the least, very often either a SPECT or a MEG or both. And then if those studies are concordant, meaning at least 2 of them line up to some area of suspect, and we think that a potential surgery is still an option for your child, then you will proceed to the phase 2, which is an intracranial recording of seizures. And that could either look like remove the bone flap, then we put grids and strips down, or we do burr holes and look at things from a stereotactic EEG method. Do you want to answer the other question?
Sure. So as far as neuropsychological testing and functional fMRI, so the neuropsych testing is pretty much always done unless the patient's too young to do neuropsych testing. And the neuropsych testing helps for several things. One is it gives you information about which cognitive domains are functioning well and which ones are not. So that it goes through, as Dr. Van Hirtum does mention, it looks at lots of things, language and memory, problem-solving skills. They also look at mood and personality. But if we're looking to see if there's sort of, a relative strength and a relative weakness, and maybe that relative weakness would be a clue that side of the brain is, sort of the problem side. Neuropsych testing is also important for tracking changes over time. So for instance, we always get a neuropsych testing before surgery and we get one after. Some centers do it 6 months after, some do it a year after, but it's pretty standard to do one after so that you can see what changes have happened. So the neuropsych testing, it gives you an idea of where these cognitive and thinking skills are like. It gives you an idea of, helps to figure out which side of the seizures or which area the seizures might be coming from. And it also can give you an idea of what you might be at risk for if you were to have surgery. The functional fMRI is not always needed. So we will do a functional fMRI if our suspect area is very close to an area of the brain that is that has like really critical functions. Like if it's near where we think vision areas are, if it's near the motor areas, So it just sort of depends on where your suspect area is as far as whether or not you would be doing functional fMRI.
If you're talking about an extensive EEG rather than the general, like, short one that you don't always show abnormal activity in if you're not having a seizure. If you're talking about the extensive version where they wean off the medication, I'm just concerned, like, if you have one, you end up going into status epilepticus, which can be damaging, as we know. Do you guys step in and administer some sort of medication or to try and stop that from continuing?
Always.
Okay, good. Yeah, because I wouldn't want that risk.
Yeah. Yes, it's a very legitimate concern, and it certainly is a potential risk of having the video EEG monitoring. But there's always somebody watching the monitors. There's nurses. At any time of the day, the physicians can log in and look at the EEG remotely. And so different centers have different protocols as far as when they're going to give, Ativan or other types of rescue medications. If a seizure's too long or if there have been too many in a short period of time, that's the usual kind of protocol for when we're going to give. And certainly if somebody goes into status epilepticus, then, then treatment is going to be given, very assertively.
Right, I know. I had one years ago before I had neurosurgery. I had electrical load broken cameras and they did extensive EEG prior, but I knew it was in a safe place because it was at USC, the research area, medical now they call it, and so it felt in a safe space.
Yes. Yeah, it's a very safe space to have a seizure.
But now, you're like, okay, would that generally be the case? Or do you sometimes run into situations where you have someone who's not, stepping up to what they're supposed to be doing?
Yeah, usually it goes surprisingly well. So I can imagine would be, of all the pieces that we perform during the phase 1 evaluation, probably the hardest thing that the patient has to go through, and the family, because scary. We don't need to record big bad seizures. All we need is the beginning of seizures. And so we usually step in. If most of the time they'll self-resolve in just a minute or two. If it's 3 to 4 minutes, we're actually intervening, and at CHLA we have a whole protocol in which the meds are already on the floor. The nurse has them in the pocket, and we intervene. So it goes well. That's not to say it's easy, but it usually.
I know one time years ago I was in an ER. It was a special center, and we brought in, and I ended up being in status epilepticus on and off for like a week straight. And that you had to relearn a few things. This is years ago. But it wasn't like extensive. I still had things to go and see my kid before and afterwards, but you did have to relearn stuff to some extent. So you don't want to be like putting that on your basis. You know what I'm saying? Just in case it went to something like that extent.
I had one follow-up to your fMRI question. So we have a few paradigms that we look at it. So everyone gets a neuropsych baseline test. Who gets the fMRI, as Dr. Shaw mentioned, depends on what area of the brain we're interested in. We know how to test language and motor. We can map those out anatomically, vision as well. What we don't have most centers don't have a great paradigm for is memory, which is where that WADA test comes into, if that child or the adult is able to, we'll pursue that.
Thank you so much. Sorry, everybody, about the AV challenges. Are you willing to take some questions outside of this crew?
Sure.
We'll do have a session starting at 1:30.